Good morning.
Good morning. Good morning.
Welcome to the Medicare Cafe. This is the pre-chat where we just hop on a couple minutes early to answer any burning questions that you have.
Burning questions.
Literally the moment of the burning questions. So I had so many thoughts this morning of like everything that I do wrong that makes people like our producers like Alex and Sadie very upset. One of them was I never drink out of a Medicare Cafe mug. I always like drink out of this now canceled. This mug isn't even allowed to be seen. I have to turn it backwards. So like I can't even like show you what's on this mug because it's it says Medicare
super
Center.
Inappropriate, guys.
That also is Olivia, too early in the morning to have those conversations. And so I never drink out of a Medicare Cafe mug, and that makes them mad.
Children's tears.
It's the tear. Yeah. Well, truly, it adds a little salt to my caramel latte.
I love that.
So that's one thing that makes everybody upset that I do constantly. And the other one was, keep in mind that we're doing the What's Brewing series. We do this during Medicare Cap. During AEP, try to keep these really short, really information-packed so that you can just get on with your day. Last week, I loved Sadie more than I love myself in so many cases. And she says, hey, idea. Maybe we quit saying that they're 15-minute episodes because not once has it been 15 minutes.
Yeah. We put a lot of people in the room that love to talk and want to just help so many people. And
it can't be 15 minutes. We do our best to keep them at 15 minutes, but girl can't be chained. She's got things to talk about people, and you guys are giving me the platform to do it.
Yeah. So this is your fault.
So as a compromise, we're no longer saying they're 15-minute episodes because she's not wrong.
They're just shorter.
But neither am I.
Right. Obviously, yeah. They're just shorter.
They're shorter. A little bit less
size, if you will.
Espresso sized.
Sure.
Packs the same amount of punch, but in a smaller container. That was clever. Don't act like that wasn't clever. Welcome to the Medicare Cafe. I also, in light of never having the correct mug, I did find this little gem. For those of you guys who don't know, this is 2 logos ago. So this logo predates me being here, not me in existence, just me being here. So Senior Marketing Specialist, you guys probably know us now as the hexagon logo with the square, and it says Senior Marketing Specialist. It's in our name. Yes. We are the specialists.
Yes.
But before that, we used to have SMS on everything. We've had 2 variations of this logo. This was the first one. So this mug has to predate. I mean, I was here in 2013, and so I think they were kind of phasing this out, but like look at that logo. We're talking this is like a 90s early 2000s special.
Yeah,
I wanted to share that
reminds
with you
me
guys.
of something I would have seen in like middle school.
That hurts my heart, but that's okay. My ego is bruised enough today by being yelled at by everybody. So anyways, I'm not going to drink out of it because there are in fact thumbtacks in there.
Spikies, yeah.
There are spikes, so I will not be drinking out of that, and I will instead be drinking out of my illegal off-market Medicare Center mug.
That's funny.
Welcome to the Medicare Cafe, What's Brewing Editions. You are joined today by your hosts. My name is Olivia Richardson.
And my name is Benjamin Lavis.
And so we just love Lavis. It took me forever to not say Laves.
It's okay. Carson still calls me Laves.
Yeah, he worked here for 6 years?
Oh, like 5-ish. 5 and some change,
feels longer.
maybe.
You're exhausting.
Yeah, that's true.
So we're excited today. So what I do, again, just to keep a reminder, this is the What's Brewing series. So they might be longer than 15 minutes, but they are still a shortened series. And just talking about what's going on, what's happened in the last week. We haven't talked to you guys since last Tuesday at 10:20 a.m. That's whenever, and so wanting to talk a little bit about like what's happened in the last week. And my gosh, there is never a shortage of content.
I need someone to find the big like staple stop button that we can hit, like pause all updates.
Stop it.
That's enough for 1 year.
Quit being
Slow
crazy.
it down, please.
I know. And honestly, like this year, I'll say this, last year was the exact same way, where it was just like every week was a new episode of Grey's Anatomy Medicare style, where it's just
this
like
time, this dude's open on the operating table.
And nobody's paying commission.
Right, truly.
So this time I think it's a little different because we know we have a little bit wrong way. We have a little clearer expectations of like the things that might change during AEP. So maybe we're just getting numb to it.
Yeah, for sure.
But there are, so I have a list. This is my list of all the changes we have this AEP. You can't see it.
Oh, sorry.
Okay. So here's the things that have happened since last Tuesday that you need to be aware about.
Okay.
Aware of. Informed about. Number 1, status of the shutdown. So today marks 35 days of the government shutdown, which is tied for the longest shutdown we've had in
We're going for a
history.
record.
Hate that.
Sorry. Wrong side of the team.
If you're gonna win something, like you're gonna win it all. Like we don't half-ass anything, including our government shutdown.
Exactly. Right.
So what does that mean? Again, we do know as far as how it's affecting Medicare enrollments on a major level. Again, Chaylin hit on this last time. Not a ton. CMS did call back, unpaid, but did call back a mass majority, like 90% of the workforce. CMS is in office, which is, of course, is running Medicare services. So as far as like processing the apps on the Medicare level, I don't think we're seeing as much of a slowdown as probably one would have anticipated.
Agree.
Just keeping in mind something that is big go hard, go home. Thank you, Sean. Something that is of note and something that's getting a lot of attention right now is those SNAP benefits. Just keeping that in mind, that's kind of what's getting the biggest attention. Obviously, SNAP representing how many Americans feed themselves and feed their families. Just want to clarify something that has nothing to do with Medicare, but an important clarification. Oh, Larissa just has an important clarification when it comes to SNAP. Yes, 2 judges did come forward and say the Trump administration does need to use these reserves. There's a thing of SNAP reserves that basically say like if there is ever a month where not enough money has been allocated that they can go into these reserves and get that much, or where there's a national emergency and SNAP needs to provide these funds. So there is a fund for that. However, it's super, super limited. They are tapping into those funds to continue that SNAP benefits, but they're a fraction of what people usually get. So
not what they're counting on.
I just want to make sure like a lot of people who do utilize and families who are worried about that, yes, there has been some relief, but it's a fraction of what they're used to receiving for the SNAP benefits.
Wow.
So not important to Medicare, but it's something that's affecting your clients and the families of your clients.
100%.
Let's get into the UHC.
I didn't know that's how you pronounce that character. Yeah, HC.
So
interesting.
So UHC. I have a toothache.
It's because you keep chewing on the microphone?
Maybe. I've had it all morning. I need to go take some Tylenol, but that snap for dramatic effect, that
Wait, which side
radiated
is it on?
this side.
I have like my wisdom tooth, I think, on this side is.
Do you still have your wisdom teeth?
All 3 of them.
That's not enough.
What? Well, I've never been that wise. That's what I bring to the cafe.
So United Healthcare. A lot of people may not be familiar with this unless you're using a third party to make your enrollments for PDP, which we'll get to. But UHC has announced that they are suppressing all of their PDP enrollments.
And correct me if I'm wrong, Olivia.
I always do.
True. They had already outlined that they were non-commissionable.
Which is the interesting part.
Okay.
So usually a plan, the last case scenario, the last thing they want to do is go non-commissionable, but these are PDP. They've been non-commissionable for
July, I want
yes,
to say.
and continued into 2026 enrollments were non-commissionable. So what's interesting, the fact that they're now going suppressed, it's like the amount of people that are enrolling into UHC's PDP, non-commissionable PDPs, it was still too high.
Even though it was non-commissionable.
Even though it's not, which is kind of what we
right.
new.
Right.
We saw that with WellCare. We saw that with Silver Script. People still enroll their clients in non-commissionable plans. When it comes to PDP, I don't disagree with that.
Right.
I know both sides of the argument.
For sure.
I don't disagree with that because you weren't getting a huge amount of commissions anyways on it. So it's kind of just like a service that you're providing.
100%.
But it was shocking that so many agents are agreeing with us as show of their actions that if it was the right plan for their clients, they were still enrolling them, causing a non-commissioned plan to go suppressed, which is just backwards from everything.
And everything that since I've been in this industry, it's always like, UHC does technically have a PDP. Technically. It's never been like a forefront focus of theirs.
They don't even talk about it at their rollouts or stuff.
So it's interesting that it's the perfect storm. Like the little gremlin and the goblin is just throwing, yes, UHC PDP's competitive now.
I know. And it's not even like that they were super competitive. It's just, I don't know. They just still were getting too many enrollments.
Well, they wanted 0, and so they got like 3, and so they're like, get rid of it.
That's probably true. Bail. So just keeping that in mind, it did go suppressed. It is still available on Medicare.gov. And what was frustrating about this, more so than any other suppression, was that UHC didn't tell anybody. People literally were just like, why is it not showing up anymore?
Well, no one enrolls them anyway, so they wouldn't notice it's gone.
Ben, when you're right, son of a bitch, when you're right, you're right.
Hey, I'm on a roll today.
You really are. Great job. So that's just something to keep in mind. It is enrollable on Medicare.gov. It is not enrollable anywhere else.
The health company suppresses a PDP plan. Can we go to the website to help enroll clients? It seemed to recall doing this on an Aetna plan a few weeks ago. Humana Value blowing away everyone on it as well.
Yeah, great question. So suppressed usually means just that suppressed could really mean two things. It can mean paper only, or it can mean just not on third-party websites. So in the case of United Healthcare, I actually don't know if Jarvis has it on there. That's a great question, Mary. I don't know if it is available on enrollment on Jarvis. I'm thinking it's not. If they're directing people to Medicare.gov, it would lead me to believe that Jarvis does not have an enrollment option.
I would agree. It would be hard.
But we don't know that I don't know that for sure.
Yeah. It would be interesting for them to service or allow the capability for like their brand enrollment.
It's like trying to make it less. It's making it less convenient.
Right.
Like if you're quoting an enrollment and your CRM is all in one platform, here's a plug for Integrity Connect, and it's all in one platform, then yes, then like to go to Jarvis is still inconvenient. Correct. But is it inconvenient enough? Because if you're not getting paid commissions on it, like how can you be more inconvenient?
It start charging you per application.
I know. You owe me money.
It's like, thank you for your services. Would you like to provide a tip?
Yeah.
Just like waiting for
the iPad. UHC with the iPad. Like, thank you for your enrollment. Tip.
Tip, please. Tic-tac officer?
Tic-tac officer. All right. Next thing we want to talk about, I had this question. I was asking our agent support team what kind of questions they've been getting, and so here's some of the questions they're getting pretty regularly from our agents. One of which was, what do you tell a client about not being paid? So like if a plan is non-commissionable, we think about this for PDPs, right? We think about that. And we've talked a lot about like how do you handle PDPs? We like the idea of you take the enrollment, you facilitate the enrollment, but you do not waste appointment time in that enrollment. And it's really interesting, especially a lot of people have 3 more days to write Humana PDPs. So a lot of people front-loaded their PDP appointments and will do their MAs after that. I understand why, but like if you look at it financially, you're putting your highest paid things as a less priority. I don't know. We don't have enough time in the world. I don't have 15 minutes. I already told you I'm not going 15 minutes, but talking about what do you tell a client when you're enrolling them in a non-commissioned plan? Yeah. I do think it is important for your clients to know if you're not getting paid. And I'm just talking particularly on the PDP side. But for example, there are a lot of really good plans that are Medicare Advantage plans that are coming up at the top of the list that are non-commissionable.
Well, I think you even said it many times before today's episode, was that we are in an era where the consumer that we're servicing and taking care of is the most self-informed and most educated than any of the consumers that we've had before. Yeah. So they're doing their due diligence, they're looking things up, and I would agree with you that I think there needs to be a level of transparency that they don't get to see unless they're using an agent. Yeah. And there is part of that is saying, hey, you're right, you aren't paying me for our appointment today, but there are carriers out there that I do count on in order to have a financial responsibility and trust in by having this partnership and contract with them to offer their products. I understand that this is one that is showcasing as, based off of your research, based off of your providers, your prescriptions, whatever it may be, it's looking like a very strong and competitive plan. I have to be transparent that if I write this plan for you today, I'm not able to, keep my lights on. Yeah. There are people out there that I think value an agent enough to go with maybe a tier less of the best. That way they have the experience, the conversation, even just having an open forum to talk about what is going on in the industry.
I think when it comes to you working with people's dollars and working with their health care, you always have to think they have tattooed on their forehead what's in it for me.
Hmm.
And so a term that I like to say when it's talking about commissions is follow the money,
Hmm.
right? A carrier, when they're saying we're not paying you commissions on this, two things happen. One, that's saying that they don't want the enrollments. Because if
Truly.
they pay commissions to incentivize enrollments, do you want to be on a plan that does not want your enrollment? That's more so, I think Christy said really well. Some clients ask, I tell them PDPs are service plans only. I agree with that. So this is more on the MAPD side. Like this carrier is saying that they're saying one of two things. One, they don't want your enrollment.
Right.
Or two, they don't want you to be serviced by a local professional. They
Right.
want you to call a 1-800 number. They do not want you serviced by a local professional. Do you want to be in? I can put you in that plan. You can be on there. You can enroll yourself. But I'm telling you, you are going to be. And if you are, and in some cases, if you want to be put on that plan, knowing that one, they don't value me and they don't want me to service you, and two, they don't want you on the plan, that I don't feel comfortable putting my
Right.
name on that line. So I will give you the information to enroll yourself into a Medicare Advantage plan that isn't paying me commissions. I want you to be aware that it exists,
Right.
but you need to be fully educated of what non-commissionable means.
I think I love it was while you were mentioning some of that, it brought me back to some of the conversations we've had in the past about how we believe, here shortly that an E&O claim could be paid out if you're not bringing up ancillary aspects.
Yeah.
I think this is an interesting line that is being kind of written in the sand that it is the agent's responsibility to highlight all of the plans that the client has available to them.
Mm-hmm.
But part of that is also outlining that why they may not recommend also all the plans available. There are certain cases, it's not always just the cost, it's not always just the network. There are member experiences that these people are going to have throughout their tenure with this carrier, whether that be this year or the following years to come. There are a lot of reasons, and I would be interested to hear if there ends up being any type of line or kind of regulation that requires an agent to either avoid non-commissionables or not avoid non-commissionables, or what does the conversations look like moving forward? So I think in all of this, transparency is king. Like
I
outlining
agree.
it and saying, hey, this is where this is at. Yes, you do have it as an option, but here are the extra baggages that you now have to carry with you when you're getting on that
I
plan in
think
that carrier.
it's teaching them about the risks. It's just being an advisor, teaching them the risks and gauging how comfortable. If you don't want to call Medicare, if you don't want to call a company, you want to work with me as your local provider that you can get a hold of, this is what's required of that, and just letting your clients make those decisions. I also am not really confident in what the word tenure means.
Your time there?
Is that what tenure means? So when a teacher gets tenure and they can't be fired, it doesn't mean they've been there for 10 years. I did make that mistake. Anyway, it's not the time. So, yeah. Okay, another question. Star ratings, do they matter? Again, we'll go through these pretty briefly. The question was, how much attention should an agent be paying to star ratings? And what's interesting about that, it has changed over the past few years.
Yeah.
Star ratings are ratings that are given to insurance plans based on how effective the plan is. CMS has some guidelines that they'll use to measure, but it's also like the provider, how the relationship with providers and their input on how that plan reacts and how that plan behaves is impactful to the star rating. And then consumers also give these star ratings. So in the past, it really didn't mean a whole lot. At most, if they had a 5-star rated plan, then they hadn't opened up an SEP. That was really all the attention these plans got. Star ratings have become a lot more of a table topic when it comes to these plans because they really greatly affect how much money that plan gets. The higher the star rating, the more resources they get and the more money they get. So doesn't matter whenever your clients go shopping. Probably it says how long is that plan going to be around, but it also kind of lets you know the health of that plan and how much money they're receiving.
Quick question on that, just because I'm curious of your opinion. Do you think that the star rating shift or more focus as of late is what's the word I'm looking for? Is like a result of the lawsuit that happened last year surrounding some of the star ratings?
I think star ratings have become so popular and so much talked about because the carriers are talking about them more.
Gotcha.
Primarily because when you limit income
Mm-hmm.
from CMS, when resources are being guarded, when you're limiting how much money that they're getting because CMS is not giving Medicare Advantage carriers as high of dollars
Right.
as they had in the past,
Right.
then you start looking at all of your revenue. Then
Yeah.
you start looking at all of your money. And now that we see that star ratings are a way that they're receiving money, so they're going to pay a lot more attention to that. And before something would have gone to a 4.5 or a 4-star plan, it'd be like, whatever. Now it's worth advocating resources to fight for that extra star.
Right.
So I think it's happening because resources were cut. So carriers are now looking at all ways that they get their resources, star ratings being a big part of that.
Agents should be familiar with some of the breakdown that you think, like how carriers are funded.
I think it should be more so about, I think agents don't need to know how sausages are made. I think they just need to know what it tastes like to the client.
You heard it here first.
A couple more quick questions. How do we enroll in SSBCI? We made a huge deal about that last time about how you should be your clients if they're especially on a DSNP or CSNP plan, if they want to get those extra benefits like grocery cards, things like that. They need to do the HAR, it's LMNOPs, the HARs.
HRAs?
Oh my God.
Are you saying HRs?
I don't know what I'm saying.
HRAs?
HRAs. They need to do them. Agents don't need to worry about a client
I would love to be able to help you, my dear.
Agents don't need to worry about enrolling their clients in SSBCIs. The carriers will do it on their behalf. The agent does need to make sure though that the providers are in check, so the providers are responding to the carriers, and they do need to make sure that my brain stopped working. They do need to make sure that the clients are doing the HRAs.
Yes.
What an intimate time we just
That
had.
was a lot of fun. We should never do that ever again. From some quick things on that as well. Like it's no different than when you're going through a chronic special needs plan enrollment anyway. You have to have that verification. Technically, that is supposed to be done on their behalf, but the client can take that form to the provider as well and make sure that is taken care of. So,
Can you guys hear us? Christy says we're muted.
well, no, we just muted Olivia's microphone.
Okay. Probably required.
So, so making sure that you were catching some of the stuff that Olivia was outlining through her.
If you
her
didn't call us, I'm
ASMR.
not saying it again.
That's super fair. Basically, you shouldn't have to worry about SSBCI being enrolled for your clients that are on CSNP or DSNP, especially those that qualify for it. I would make sure in your CRM that you have a notation that the client does qualify for either DSNP or CSNP. That way, if you ever need to kind of cross-reference or cross-check is what I was thinking
Yeah,
for.
it's fun, isn't it? Having
yeah.
a stroke on TV. Just not even a TV anymore. I'm a boomer.
Yeah, our TV. So just make sure you have that kind of notated in your CRM. That way, if you ever need to go back through, get the piece of paper taken care of by the provider, then you have all that capable and available to you. But it shouldn't be something you have to proactively worry about too much.
I'm moving on.
Yeah, I'm with you.
You nailed it. You did really well.
Thanks. I needed that.
Okay. 2 more things. Formulary exceptions. Whenever you are running a prescription for somebody and you cannot find a single Part D or Medicare Advantage plan that covers that prescription, I will tell you most commonly, not the only time, but most commonly, we're seeing this happen a lot more because of what the Inflation Reduction Act has done to prescription drug plans. They're really tightening those formularies. Where you're going to see this more often is that brand name medications are not covered, period. And so they are forcing people to get on generic medications. A lot of times, whenever the difference between a generic medication and a brand name medication is, one, brand names have better actors to portray the bad things that happen. Generic plan or medications have the same active ingredients, but different non-active ingredients, aka dormant. I don't think that's the correct word for that, but I like it and we're sticking to it. Oftentimes, people will have reactions or something will cause the active ingredient to not work as well in certain individuals, meaning that they have to take the brand medication. They cannot make the generic. If they do that, A provider is allowed, it has to be done on the provider level. A provider is allowed to file an exemption for that medication to say we cannot, and say the reasons we cannot take the generic. It must be the brand. So the provider can submit a exemption for that. It doesn't normally go to the same tier though. So if that medication is a tier 1 or tier 2 medication, it'll likely go to a tier 3 copay or co-insurance because it would be considered that. So you can oftentimes get it on the formulary if the provider submits an exemption, but it won't be at that same tier level.
Which is still important because
At least
then
they
it
can get it.
allows it, one, for them to get it, but two, also then it's subject to the $2,100 maximum out of pocket for the prescription drugs. So these are definitely good and important aspects to try to make sure. And some of the things that we were talking about, I know Kendra outlined this earlier to us as well, that if you are using Integrity Connect, there are, under the Learning tab, you should be able to grab either HRA information or some of those verification codes or forms from within there when you go to select on the carrier logo. So if you are already using the best platform out there, that's another reason why you were intelligent and super smart and you're my favorite for using that platform, and you can take care of all that.
Michelle added, some will be tier 4. Yes, it'll just likely be tier 3 and above if you do get that exemption on there. You had a thought. I saw it.
I'll let it go.
It was so. Do you?
Okay, it'll come back around.
Okay. Choo. Last thing, and then we're out of here. Is the Connect, an Integrity Connect. Troubleshoot, more of a clarification. So, okay. So one of the biggest questions we're getting right now, their agent support team is getting, is basically providers. I think Rachel Brandmeier mentioned it. Our support team mentioned it, that like everybody is very aware and acutely watching providers, because as we know, the relationship between provider and plans are strained right now. Yeah. Many providers are saying we will not agree to those negotiations. So everybody's really, really watching providers right now. So when you're on Integrity Connect, this is actually a really positive thing. It seems like it's really frustrating. I know you're like, Olivia, you're in sales. Of course it's going to sound bad, but actually be great. It's really true though. So when you're on Integrity Connect is a platform that is quoting and enrollment all in one CRM that does let you know if a provider is in or out of network for a plan. Here's where people get a little silly and get a little frustrated, understandably so if you don't understand it.
Right.
Other platforms will just look at either a hospital network or look at a doctor and say in network, yes or no. Integrity Connect makes you go a step further. It makes you confirm the address in which that provider is at. That seems like an unnecessary step because no other platform requires you to do that. Here's where you're wrong. So with Integrity Connect, what's interesting about these providers is that these providers can work out of different locations and work with different hospital networks. If they work, because the location is tied to the hospital network. So you can have the same provider at this location, they are in network. At this location, they are not in network. So that's why it's very important why Integrity Connect goes the extra step and says, please confirm the address to make sure that where you're used to seeing this provider is in fact in network. If they are not in network, no worries, just start seeing them at this other location. So it seems troublesome, it seems annoying, but it is absolutely worth it. We've seen a lot of people, they go into and they enroll somebody and then they try to go to the provider and the provider says, no, I'm not in network here because I'm in a different hospital network when I'm in this location. Yep. So it is really important. It seems unnecessary, but it is something that does kind of take it to the next level.
I actually just experienced that with some hearing and ear testing that I literally walked across the parking lot to a different location for like a testing site instead of where I was viewing or having like my appointment with a provider.
Yeah.
And the bill was drastically different because of that
literally
300-foot walk.
It's the silliest. And like, I don't know, all of us is the silliest.
They see Illinois isn't allowing HRAs. I have seen a couple of different states hop on board with either different commission aspects or HRAs, but I'm not sure I recognize Illinois as one of the ones in my memory bank. I can do a little bit of looking up for us, Jeanette, and we can piece that together.
I know we have several team members on. I see Sean and Brittany. So if you guys know anybody that's, let us know. Text in or text me. Again, I know I normally say this. I didn't today, but that is my real phone number. So if you guys text me at any time, I do like to make sure I respond. It is real. I do get some random text messages from people that are just like, da-da-da. I'm like, and then I respond. They're just like, whoa. I'm like, I promise, like, I don't have enough friends. If you're going to text me, I will text you back.
It's
Like,
right back.
I'm very lonely.
It's like the you up, and then it's like as soon as you send the bubbles start typing, you're like, they were too ready for that.
They were too ready.
For that.
They were too ready.
Back it up. Mary did mention that negotiated drugs for 2026, will they have a lower tier? Now, Mary, when you're saying negotiated, are you saying for like the Inflation Reduction Act, the ones that are being put on those, like every year there are 10 drugs that are listed that are kind of put a gold stamp of approval near them, and it's forcing the formulators to have those acceptable? Or what exactly are you outlining for as like negotiated drugs?
Yeah.
And we may need to connect on that one with either our support team or us. I know we're trying to keep it under 15 minutes.
And we're at 28 minutes. Again, Sadie is right. Sadie said, quit saying it's going to be 15 minutes. Sadie's always right, and I know that. Quit saying it's going to be 15 minutes. It's not going to be 15 minutes.
Yes.
Quit trying to make 15 minutes happen.
Joel, Mary wants us to do 10 minutes. No, I'm kidding.
10 minutes. Mary says do less, actually.
The 10 drugs. So those would have been outlined prior to going into a lot of the different plan benefits. But I don't think the tier should change while they are been negotiated for 2026. But we will find out the next 10 closer to September, October next year.
And just keep in mind with those negotiated medications, most carriers are actually hurt by they're saying, oh, negotiated medicines. That's like not necessarily what we're paying. It's what the carriers are paying, you know, for those medications. So you would think that those costs would be reflected for us. However, those negotiated medications oftentimes hurt the carriers because after the price negotiations are done, they no longer qualify for the extra. What am I trying to say? They get extra, like not coupons. It's coupons, but a corporate level.
Yeah.
Anyways, and they no longer qualify. There, thank you. They no longer qualify for those. Guys, that is what we have for the Medicare Cafe What's Brewing episode. Like I said, every single week, I'm like, it's been a pretty calm week. I've never said that. But I think, you know, it's been a pretty calm last 7 days. Surely the updates won't be that much. And then I'm always just humbled by how much happens within a week.
Truly.
So,
Truly.
Ben, thank you for being a friend.
Of course.
My friend, thank you for hanging out with us.
Thanks for having me.
I'm the happiest.
Sometimes I just throw some curveballs.
Rebates. Thank you, Mary.
Like Menards.
Saving money at Menards.
Today.
Is that weird guy? He looks the cartoon dude. Is Menards a Midwest thing or does?
I think so. Yo, raise your hand in the chat if you like Menards.
So funny story. So when I was in college, it has nothing to do with Menards.
Oh, well, that's even crazier. Okay, I'm down.
So when I was in school, I was seeing this in college. I was seeing this guy. He was from Chicago. And so we were talking about, and a big group of us needed to go to Walmart. And what do we call Walmart here in Missouri? We call it Wally World. And so we're like, hey, we're going to run out to Wally World. We got a big thing we got to do and all this stuff. And this guy was pumped to go to Wally World. He was like, heck yeah. He got ready and he was talking like, what time we leaving? I'm like, I don't know, my guy. Just got to grab some groceries. A whole group of us going to Walmart. We pull up in the Walmart parking lot and he was devastated. Like 2 weeks later, he finally admitted, I thought we were going to a theme park called Wally World.
Born and raised in Missouri, I've never
You've never called it Wally World?
Wally World.
Yeah. Yeah,
Wally World?
He was devastated that we were going to Walmart. He thought we were going to a theme park. Now, he won't watch this because...
I'll send it to him.
Okay. But yeah, just if anybody reaches out to him, know that he was put on blast here on the Medicare Cafe.
No, I'm with him. I stand with mystery
ex-boyfriend.
Yeah.
He literally was like in like shorts, like I mean like everything minus like the white sunscreen on his nose. Like he was ready to go.
Little fan necklace was ready to go and everything.
So excited. Thank you guys for hanging out with us. Join us next Tuesday at 10 a.m. to get your AEP updates on the next episode of What's Brewing. So until next time, y'all have fun.
Make money.
And give impeccable service. Oh, you're so good at that.